Welcome to the MediByte channel. I'm here as your healthcare professional to walk you through today's explainer. We're going to be diving into two of the most critical complications that can happen during pregnancy: preterm labor and stillbirth. We'll be looking at the clinical guidelines from the MSD manual to really unpack the definitions, the causes, and the treatments of these medical events. Now, I know these are heavy topics, but understanding the clinical realities, that's incredibly empowering. So let's get right into it. Here's our roadmap for today. First, understanding preterm labor. Second, treating preterm labor. Third, defining stillbirth. Fourth, the causes of stillbirth. And fifth, medical and emotional care.
Section 1. Understanding preterm labor. Labor basics.
So the foundational medical baseline here is all about time. Preterm labor is strictly defined as labor that kicks in before 37 weeks of pregnancy. And this timeline is, well, it's incredibly sensitive. Babies born prematurely can face some pretty serious health problems simply because their organs haven't fully matured yet. Doctors will specifically try to prevent or stop labor if it begins before that crucial 34th week. You might be wondering, why that specific window? Well, premature birth carries a high risk of bleeding in the newborn's brain, which can prevent normal development and even lead to conditions like cerebral palsy.
Now, while we don't entirely understand the exact triggers for preterm labor, there are some major risk factors we absolutely have to look out for. For instance, if a mother has had a previous preterm delivery, her risk naturally goes up. Infections are another massive factor here. This includes genital infections, kidney infections, or infections of the membranes containing the fetus, which we call intraamniotic infections. There are also physical factors, like structural weakness of the cervix, known as cervical insufficiency. Plus, carrying twins or triplets or having abnormalities in the placenta, uterus, or the fetus itself can all elevate the risk. This is exactly why regular prenatal visits are just so crucial. Doctors really need to catch these potential problems early on.
Section 2. Treating preterm labor. Clinical management.
Okay, so what actually happens when a doctor diagnoses preterm labor? Let's walk through the clinical protocol, assuming there's no vaginal bleeding and the amniotic sac hasn't ruptured. Step 1. Doctors usually advise the woman to rest, limit her activity, and push fluids. If that doesn't do the trick, they might introduce specific medications to slow down the labor. At the same time, doctors often administer antibiotics while they wait for culture results from the cervix, vagina, or urine. If those cultures come back negative for infection, they'll stop the antibiotics. And finally, corticosteroids might be introduced, really depending on how far along the pregnancy is. Let's take a closer look at those medications used to delay labor. Doctors typically have to choose between two main categories here. First, we have calcium channel blockers. These are usually used to treat high blood pressure, but they can also slow down contractions. The catch? They can cause side effects like headaches and low blood pressure in the mother. On the flip side, we have prostaglandin inhibitors. Now, these are effective, but they come with a really major caveat. They might temporarily reduce the amount of amniotic fluid, and they're absolutely not used after the 32nd week of pregnancy. Using them too late can actually cause heart problems and kidney damage in the fetus, which is obviously something we want to avoid.
Now, what if delaying labor just isn't possible, or the membranes rupture between 23 and 34 weeks? At that point, doctors shift their focus entirely to protecting the baby's development. This is where corticosteroids become absolutely essential. They act fast to accelerate the maturation of the fetus's lungs and other organs, which drastically reduces the risk of respiratory distress syndrome after birth. Also, if the pregnancy is under 32 weeks, mothers might be given an IV of magnesium sulfate. This specifically reduces the risk of bleeding in the newborn's brain, which, as we touched on earlier, really helps protect against developmental issues like cerebral palsy.
So, we've covered the intense efforts medical professionals make to preserve life during early labor. But we need to take a moment now and ask a really difficult question. What happens when a pregnancy faces an even more severe, tragic complication after the 20-week mark?
Section 3. Defining stillbirth. Fetal demise. In medical terms, stillbirth, which is also clinically referred to as fetal demise, is defined as the death of a fetus at 20 weeks of pregnancy or later. If we strip away the emotional weight just for a second to look purely at the clinical reality, this definition marks a very distinct timeline difference from a miscarriage. It anchors the event firmly to the latter half of the pregnancy timeline. Now, what's really interesting here is the variance in global medical standards. In the United States, stillbirth is categorized as fetal death before or during birth at 20 weeks gestation or later. But the World Health Organization uses a completely different timeline.
They define stillbirth strictly as fetal death after 28 weeks. Understanding these differing definitions is really crucial when medical researchers and doctors are analyzing global maternal health data. And speaking of global data, this next number is just staggering. 2 million. There are almost 2 million stillbirths worldwide every single year. It is a profound, widespread medical event. It impacts millions of families and continuously challenges healthcare providers globally to find better methods for prevention, diagnosis, and care.
Section 4. Causes of stillbirth. Identifying the factors.
To understand prevention, we obviously have to understand the root causes. It is important to state right up front that sometimes, tragically, the exact reason for a stillbirth remains a mystery, even after thorough medical testing. But when a cause is identified, it usually falls into one of 3 buckets: the mother, the placenta, or the fetus. Let's start with maternal health factors. A fetus may not survive if the mother develops severe conditions like preeclampsia, which is a really dangerous type of high blood pressure during pregnancy. Blood clotting disorders, like antiphospholipid syndrome, are also significant risks. Other maternal factors that create danger include poorly controlled diabetes or thyroid disorders, severe obesity with a BMI of 40 or higher, and the use of substances like cocaine, alcohol, or tobacco. The second category involves issues with the placenta. And remember, the placenta is the absolute lifeline for the fetus. Complications here are highly dangerous. We're talking about things like placental abruption, where the placenta detaches from the uterine wall way too soon. There's also the risk of a prolapsed umbilical cord, which is when the cord comes out of the vagina ahead of the baby. One particularly severe condition is vasa previa. This happens when the membranes containing the blood vessels connecting the umbilical cord and placenta lie right across or even near the opening of the cervix. This can literally cut off oxygen and nutrients to the baby. And of course, infections in the amniotic sac can also be a lethal factor here.
Finally, we have to look at intrinsic fetal issues. Sometimes, a stillbirth can be the result of a severe chromosome or genetic abnormality, a major birth defect, or fetal anemia, which simply means the baby has too few red blood cells. On top of that, pregnancies involving multiple births, twins or triplets, just inherently carry a higher risk of fetal demise.
Section 5. Medical and emotional care, support and recovery. Understanding these complex causes leads us directly to the medical interventions, and of course, the profound emotional care required when a stillbirth is suspected or confirmed. The diagnostic process often starts when a mother notices the fetus has stopped moving. Now, while movement naturally decreases as the growing baby runs out of room, doctors will immediately run tests to evaluate viability. They use a non-stress test, which involves attaching a device to the abdomen to monitor the fetal heart rate while it's still and while it moves. They'll also do a biophysical profile using a real-time ultrasound to closely check things like amniotic fluid levels, rhythmic breathing, and muscle tone.
If fetal demise is confirmed and the fetus isn't naturally expelled, prompt medical intervention becomes absolutely necessary. Doctors will typically administer a prostaglandin, like misoprostol. This is a hormone-like medication that essentially tells the uterus to contract and helps the cervix dilate. Then, depending on the stage of the pregnancy, oxytocin is given to induce labor. If the pregnancy is under 24 weeks, or if the fetus is quite small, doctors might opt for a surgical procedure known as dilation and evacuation, or they might use suction curettage to safely remove any remaining tissue from the uterus. This swift medical intervention isn't just standard procedure, it's critically necessary for the mother's safety. If a deceased fetus remains in the uterus for weeks, the mother is at a really high risk of developing a severe clotting disorder called disseminated intravascular coagulation, or DIC for short. This disorder can cause massive, highly dangerous bleeding that requires immediate blood transfusions to stabilize the patient. So the physical safety of the mother is absolutely paramount during this time. As we move into the recovery phase, it's really vital to realize that the physical postpartum care for a woman who has experienced a stillbirth is exactly the same as for a woman who has delivered a live baby. Her body has gone through the physical trauma of birth, but the psychological aftermath, that is vastly different. The grief experienced is profound. It mirrors the intense loss of a miscarriage, but it's often complicated by the late stage of the pregnancy. Because of this, clinical guidelines stress that robust emotional and social support, including professional counseling, isn't just an extra step, it is an absolute necessity for full medical recovery.
We've journeyed through some tough territory today. The strict medical definitions, the desperate clinical efforts to stop preterm labor, and the sobering realities of fetal demise. It's a real testament to how complex and delicate human pregnancy truly is. As we wrap up today's explainer, I want to leave you with a thought to consider. With the profound physical and emotional complexities of these complications, how can medical science not only continue to improve diagnostic and prevention, but also revolutionize the way we provide comprehensive, empathetic postpartum support? Thank you so much for joining me today. If you found this information valuable, please like, share, and subscribe to the MediByte channel for more clinical insights. Keep exploring and keep asking those vital questions.